welcome again to Ted Schwartz from New York. I hope everything is okay from COVID-19 point of view there.
Yeah, there's definitely more cases, but the hospitals are not shut down because we know how to manage them. We're managing them better. We're still doing our elective cases. So, and I think we're pretty much at our peak, and we'll be heading down over the next couple of weeks.
Yeah, because just 3 weeks ago, I was in London and things were not looking that great. In Pakistan, alhamdulillah, maybe it's the grace of God, I think we are doing quite well from COVID-19 point of view. And we are ongoing with our elective practices. And congratulations on having a new president as well. And as I said, you're facing the onslaught of our whole endocrinologists and neurosurgeons. Neurosurgeons know you very well, and I'm sure endocrinologists know you very well now as well, as one of the leading minimally invasive neurosurgeons in the world, I would say, especially for me as well. So can you go ahead and, I'll just introduce you briefly and tell that you'll be talking about, I think you can carry on yourself, Ted. Can you do that?
Yeah.
Because you'll be talking about the whole surgical aspect of treating functioning and non-functioning tumors.
Yeah, absolutely. So first of all, I just want to thank you for inviting me to speak. It's really an honor and a privilege to speak to many of the endocrinologists and surgeons in your country. I've not yet been to Pakistan. I've been to India. I've been to nearby countries. So I'm hoping someday to come by and visit.
So I'll tell you something. We are in the capital, Islamabad. This is one of the most beautiful cities in the country. So you've got mountains, water, everything here. So you're more than welcome in due course.
Yeah, I love it. When the time comes and it's more safe, although I've been vaccinated, so I feel comfortable traveling now, but things certainly have not opened up yet. So I'm going to talk a little bit about my experience as a neurosurgeon treating pituitary tumors over the last 20 years. And we started doing endoscopic surgery pretty early on. And so we're able to contribute to some of the literature on endoscopic technique. And now we have some longer term outcome data that I can present to you since we've been doing it for quite some years now. So I want to start out by just talking a little bit about the technique, although we know a lot about it, and I don't want to reiterate that stuff, but I want to talk a little bit more about results, results of reoperation, some complications, cellular hematomas that we sometimes have to battle with, the use of intraoperative MRI scan, comparison to endoscopy. We've done some research on that. We have some new long-term outcome data that I want to talk about, as well as some data on the role of radiation therapy, which was already touched on. And then I also looked at my own learning curve over a large number of cases to see how I was doing, to grade myself and see where I was improving, where I was potentially not improving. And then I will mention a little bit about COVID-19 and what we did during that period of time. But the bulk of my talk is going to be on a couple articles that we've published in the last just 2 or 3 years on long-term outcomes and some comparison studies. So we're at Cornell in Manhattan and work at New York Presbyterian Hospital, which we share with Columbia, but I'm on the Cornell campus. And we've been doing minimally invasive surgery myself, and starting out with my ENT colleague, Dr. Vijay Anand, and some other neurosurgeons have now, ENT surgeons have been helping me over the years. So the first issue to address is, why do we need to have a center of excellence? You've talked about your own neuroendocrine center of excellence, and we consider ourselves a center of excellence. And as you know, there are a lot of neurosurgeons around the world, around the country, who do pituitary tumors, but they don't do a lot of them. And it's become very apparent, and I'll talk about my own learning curve, that the more you do these surgeries, the better you get at them. And if you just do even 5 to 10 a year, it's really not enough to become really good at these surgeries. And it's important to be really good at it, because this is a chance to cure these patients. If you know a few special techniques to get out the entire tumor, you can really make a big difference in people's lives. And if you are not a specialist, your outcomes are not as good. And that's why it's important to refer these patients to neurosurgeons who specialize in pituitary tumors. And we have a neuroendocrinologist that we work with at Cornell that I really pushed hard to hire so that we could work together. And we try to see all our patients together, and have also a very active endocrine unit and interventional neuroradiology for inferior petrosal sinus sampling, all the techniques that you need to try to have a comprehensive center to give the best care to your patients. So I've done about 1,500 endonasal endoscopic cases, and roughly half, or a little more than half, are pituitary tumors or endocrine cases, including craniopharyngiomas and Rathke cleft cysts. And as you've seen with the breakdown, the majority of these that we operate on are the non-functional adenomas in my case, because I tend to get referred a lot of large tumors that invade the cavernous sinus, invade the suprasellar space, to use our endoscopic techniques to resect them. But we've also done quite a few hormone-producing tumors as well, with a roughly amazingly equal distribution of all the different tumor types. I'm not going to talk about craniopharyngiomas or Rathke cleft cysts today. So we started doing endoscopy. Our first case was in 2003, late in 2003, and really started gangbusters in 2004, which was relatively early compared to the rest of the world. This is the setup we use. I tend to use a scope holder when I do my surgeries, as opposed to using an ENT surgeon to hold my scope. It's just how we started doing it. I'm very comfortable with the scope holder. I move it around a lot, but I like to have my eyes steady during the operation. And we have navigation, as most people do, at the head of the field, and then we have 1, 2, or 3 screens for different people to observe. All the surgeries are done through the nostrils. We don't make any incisions. Either the nostril, the scope is almost always in the patient's left nostril, and I'm on the right side operating. And then sometimes I'll elevate the scope and work binostrally, binarially through both nostrils. And sometimes I'll lower the scope and I'll work only through one nostril. But it allows you access to both the right and the left side with ease and fluidity. We wrote this book probably 10 years ago now on endoscopic pituitary surgery, myself and Dr. Anana. We actually just published another one on pediatric surgery that I don't have a picture of here, that just came out. So as has been discussed already, and I'm really not going to go over that much of the history and incidence and epidemiology, but pituitary tumors are fairly common. It's one of the more common tumors that we deal with in neurosurgery. And so, it gives us a reasonable amount of volume to deal with. Many of these we do not operate on, and we've discussed a little bit what the causes and the reasons we operate on these different tumors are. But as you did describe them as well, I tell my patients, I sit with them and I say that, pituitary tumors come in 2 flavors, like 2 flavors of ice cream, to help them understand what they're dealing with. And those are the hormone-producing tumors and the non-hormone-producing tumors. And obviously it becomes much easier to think about them in this way. And the hormone-producing tumors tend to be smaller because we identify them earlier in their course when they're making hormones, they're causing abnormalities around the body. Whereas the non-hormone-producing tumors, we really don't identify them until they get big enough to push on the optic nerves and cause visual loss, like this classic bitemporal hemianopsia, or hypopituitarism, or mild elevation of prolactin, which you went over in great detail. And those talks were fantastic from an endocrine perspective. Cushing's disease, obviously I like to think as a neurosurgeon that we own this disease. It was invented and described and discovered by the foremost pioneer and leader of our field, Harvey Cushing. So, it's a disease that we want to maintain an involvement in, I will say, and it is curable with surgery. And so, it's really very satisfying to cure those patients. And the same is true of acromegaly. I mean, it's a fascinating disease when you see the patient walk into your room, and often you can make the diagnosis you don't even need the endocrinologist to show you the growth hormone. You just look at their face and their hands, and you ask them, how long have you had acromegaly? And they smile and they tell you about their history. And so it's another fascinating disease with how it changes appearance and also the medical comorbidities that come along with acromegaly, which you've already discussed. Now, one interesting thing we found was that because pituitary tumors cause visual loss, a lot of our patients who are in their 70s or 80s who have pituitary macroadenomas, will come to us and say, well, I was losing my vision, and my doctor recommended, I saw my optometrist, my ophthalmologist, they said I should get my cataract fixed. So I got my cataract done, and my vision got a little better, but it really didn't get that much better. And then they found I had a pituitary tumor. And so we decided to look at the incidence of cataract surgery in patients over age 50 with macroadenomas and chiasmal compression. And it turns out it was 2.5 times the amount of the incidence of cataract surgery compared to patients who don't have macroadenomas. And it became apparent that a lot of these patients are having unnecessary cataract surgery, and their visual loss is really being attributed to or caused by their pituitary tumor, and it's being attributed to their cataract surgery. Now, some of these patients do have cataracts. They have mild cataracts that are seen, but it's not the main cause of their visual loss. And so it was an interesting observation we had, and we wanted to see if we could confirm it with a study, and it was borne out comparing to national averages. So if you do see a patient with an elderly patient who's come in, the cataract is not necessarily the cause of their visual loss, but there's usually a component from each. So they'll get somewhat better when you take out their pituitary tumor, and they'll get somewhat better when you take out the cataract. But if you do both, they get even better. The surgical objectives we have with non-hormone producing tumors is different than hormone producing tumors. So for non-hormone producing tumors, which are generally these macroadenomas, the first goal is to relieve mass effect. And most of the time we can get a gross total resection. We try to do that. But if you can't, it's okay. As long as you decompress the chiasm, if you leave a small amount of residual tumor in a slow growing benign tumor that is also susceptible to radiation, it's not the end of the world. So we don't want to hurt our patients first and foremost. But we can get into the suprasellar cavity, we can get into the cavernous sinus and take out quite a bit of tumor very safely from those areas. And it should be done, because the less that's left behind, the less likely they'll need additional treatment. I'll talk about that when I mention long-term outcome. But leaving residual in the lateral cavernous sinus, which is where all the cranial nerves are, is fine. And you don't want to damage those cranial nerves in the lateral cavernous sinus. You don't want to be overly aggressive just because you can go into that area. Because we can treat it with the gamma knife, and having a cranial neuropathy after an aggressive lateral cavernous sinus debulking in a non-hormone producing tumor just doesn't make any sense to me, and that should really never happen. But leaving residual tumor next to the optic nerves is not okay. We really want to get that tumor out. We don't want to be radiating the optic nerves. We don't want tumor to grow back and cause compression of the optic nerves. So those are the goals of surgery. For hormone producing tumors, you really have to get the whole tumor out, right? So you don't want to just debulk the tumor, although there are some indications for debulking. But for the most part, you want to take the whole tumor out, and that's what's going to cure the patient. And in that situation, being more aggressive in the cavernous sinus is okay if you think you can get a hormonal cure, although you can also cure it with stereotactic radiosurgery if you just have a small residual in the cavernous sinus as well. And the key here is really to find the pseudocapsule. And the pseudocapsule is important not just for microadenomas, it's just as important for macroadenomas. For microadenomas, you try to take them out all en bloc in one piece. And for macroadenomas, you may debulk the tumor first and then find the pseudocapsule and take out the top of the tumor. But we also know for hormone-producing tumors, it's incredibly important to remove the adjacent dura, and that includes the medial wall of the cavernous sinus. So we often extend our surgeries and take out the medial wall of the cavernous sinus, even if the tumor, it looks like it's just in the sella. If it's touching the medial wall of the cavernous sinus or the dura inferiorly, I will remove that adjacent dura to make sure we get a cure. And the pseudocapsule concept was given to us by Ed Oldfield, who really changed the way we take out these tumors, in my opinion, and described the pseudocapsule in Cushing's disease, although you do find it in almost every tumor. And this is the concept of invasion of the cavernous sinus and dura surrounding the tumors that was described many years ago by Ed Laws. Just showing you the bigger the tumor is, the more likely it is to invade the surrounding dura, including the medial wall of the cavernous sinus. And it happens in every tumor type and more common in repeat transsphenoidal than in primary transsphenoidal. So it's just something to be aware of. This is that same study done in Cushing's patients by Ed Oldfield, so I'm showing that the larger the tumor, the more likely the dural invasion was going to be. And again, indicating the importance of removing that medial wall of the cavernous sinus. So, it's something you hear about. It's been sort of revisited now with endoscopic techniques, but this was described a long time ago and was well known in that time. So here's an example of that en bloc resection. Now, sometimes these microadenomas they don't present to the surface of the tumor, and you really have to cut in. They don't present to the surface of the gland, excuse me. You have to cut into the gland a little bit in order to find that pseudocapsule. So I use here an 11 blade because it's just the sharpest blade I have to use, and find the pseudocapsule and then start to come around it gently. And the goal is to not have the tumor explode on you, and try to get it all out, and just gently do bimanual dissection to get the tumor out. And here I'm taking my time. You know, you don't want to be too excited and overly exuberant and crush the tumor, but try to take it in one piece. If you get the whole tumor out in one piece, the chance of cure is extremely high. It's probably 100%. And the cortisol levels will go down rapidly. We check ACTH and cortisol every 6 hours in our Cushing's patients. And as soon as the cortisol goes below 2, we start to replace them. But we do like to keep them in the hospital. And if you take it out piecemeal, it can take days for the cortisol to come down, 2, 3, 4 days. But if you take it out on block, it comes down, you know, in 6 to 12 hours. Here's another example of a microadenoma, and you can see this tumor is in the middle of the gland. So I'm thinking when I go into a surgery like this, that I need to cut in and remove a good 3-4 millimeters of normal pituitary gland before I can get to that tumor. And it is possible to remove probably 50% of the pituitary gland, and it'll work normally. And we often do that when we have a Cushing's case where we can't see the tumor and we only know the lateralization. We may remove the lateral half of the gland. So here's the case here. We're opening up the dura. I use a little sickle knife, and then I use micro scissors, try to open up the dura and not get into the pituitary gland itself. And here I'm cutting out a wedge of normal pituitary in order to find that tumor. And I use an 11 blade and really dissect into the tumor. But I know where it's going to be, and then I find the pseudocapsule and use that same gentle bimanual dissection technique in order to come around the tumor to try to take it out in one block. If I can't, obviously I'll take it out piecemeal, and then I'll try to find the pseudocapsule and get that out. But if I can get it out on block, you know, it's just a more of a guarantee that the patient will be cured, and also that the normal pituitary gland will be left intact. So there's the removal. There's no CSF leak there. There's no need for any complex reconstruction. This just shows you the histology from that particular patient, where you see the pseudocapsule, which is just compressed normal gland around the outside of the Cushing's ACTH producing adenoma. And here's that post-op scan, and you can see the stalk is still in contact with enough of the pituitary gland on either side and front and back. The posterior pituitary is intact as well, to maintain normal hormone function, even though you have cut into the gland a little bit. It is safe to do that. For these small microadenomas, I often try to save the mucosa and not just destroy it. And then you can actually reapproximate the mucosa at the end of the operation to try to maintain normal nasal function, which is also important. For non-hormone producing macroadenomas, it's a different strategy. You can see the tumors extend into the suprasellar cistern, and often we have to remove a bit of the tuberculum or the planum in order to get a good view superiorly and to be able to manipulate the tumor above and find that pseudocapsule. And you can see using this is an old navigation system, just how you can figure out how much of that planum you need to remove and how much tuberculum in order to get to the top of the tumor. And we try to open up all the way to the medial optical carotid cistern, which is this arrow, and really a bit of the tuberculum. We often don't take that much of the planum. That's really preserved for craniopharyngiomas and meningiomas. For pituitary adenomas, usually just a bit of the tuberculum is all you need. So often the sella is enlarged in these cases. So we open up the sella. I like to do a vertical cut followed by 4 lateral cuts in order to widely expose all of the tumor, dissect the dura off the capsule of the tumor, try to find that plane, come around and dissect the dura, and then we'll internally debulk the center of the tumor and the bottom of the tumor, and then start working laterally. And you can see that you can find that pseudocapsule. So there's the normal pituitary gland, and I'm just working my way around the capsule of the tumor, trying to preserve the pseudocapsule as I go. I usually go inferiorly, laterally, and then superiorly. In this case, we were able to get it all out. And here's the closure. We'll use some Surgicel and some Flow Seal. And then for a big tumor like this, we generally harvest a flap up front because the risk of leak is pretty high. For small tumors, we don't, and I usually cover it with some kind of a glue, absorbable glue. The arachnoid can herniate down in the middle of the surgery during macroadenomas. And in some of these very big tumors, I'll put in a lumbar drain. I tend to reserve it for the ones that are really 3 centimeters or bigger. You can either open that lumbar drain or you can just take a cottonoid and retract the arachnoid. So here, the arachnoid is herniated down. We still have a lot of tumor left. So I'll take a patty and I'll put it in and just retract upwards on the arachnoid so I can see laterally, get out the rest of the tumor. In this case, I'm closing with a little bit of fat. Sometimes we really don't use fat unless there's a leak, a significant leak. So a few tips. I harvest a flap if there's a high risk of CSF leak, tumors greater than 3 centimeters. You can also do a rescue flap, harvest it only if needed. Consider lumbar drainage if there's a high risk of CSF leak. We use lumbar drains less and less now, but for tumors that are very big, it is useful. During the surgery, it'll retract the diaphragma, maybe decrease your risk of having a big CSF leak, and then you can always leave it in if there's a big CSF leak for a day or two afterwards, just to decrease the pressure on your closure. We're using less and less fat. I'm trying to use inlays of grafts that we can get off the shelf so we don't have to make additional incisions in patients. And then it's very important to stop bleeding to avoid a post-op hematoma. And these giant macroadenomas, they often will bleed afterwards. And sometimes you have to go back in and evacuate a hematoma the next day because the vision gets worse. So I'll try to bipolar the cavity, shrink it a little bit, do a lot of irrigation, use Surgicel over gel foam because it won't enlarge as much. So here's an example of a larger tumor. You can see this macroadenoma is extended down to the clivus. It's in the occipital condyles. It's around the carotid arteries, and there's a suprasellar component. So in this surgery, we harvest a vascularized flap, remove the septum, open up the sella. And then, the advantage of the endoscopes is you get a really wide view and you can look around in many directions. The Doppler is very useful in these cases to find the carotid artery, to make sure that you know exactly where it is. Do a very wide opening in the dura after a wide sphenoidotomy. This is an older 2D standard definition image, but so we're dissecting free, we're removing the tumor, the arachnoid is bulging down, you can see the large arachnoid, we push it back out of the way and just keep removing tumor to the back of the clivus. There's some fibrous tissue, sometimes these are very fibrous tumors that need sharp dissection. And then to go laterally and inferiorly, we open up between the eustachian tubes, take down the basopharyngeal fascia, expose the entire clivus, because this tumor has gone down to the bottom of the clivus. And then we use our 45-degree scope and our angled endoscopes to follow the tumor, which is really cored out the entire clivus into the occipital condyle. You can see the hypoglossal nerve at the bottom, get out the whole tumor, and then close with a flap, some glue, some flow seal. You'll see post-op, we were able to really core out the entire clivus. And with angled endoscopes and angled instruments, you can follow into every nook and cranny of this tumor to really try to get as a gross total resection as best you can, even in these large, extensive tumors. I show this picture, I was given permission. This is a patient of mine who had a young girl. You can see her on the left at age 9, and she had a diagnosis, this is age 11. She's bigger than her mom at age 11 because she had gigantism from acromegaly. And she went to another surgeon and had surgery, and they took out the sellar part of the tumor and they left the suprasellar part and said it was unresectable. And actually they did it endoscopically, which just shows you why experience is so important. So her mother found me and came to me, and this was the image that I was greeted with, which shows you a nice big chunk of suprasellar tumor, a prior transsphenoidal approach that was not done adequately. And I told her, look, I think I can go back in, take out the suprasellar tumor, and maybe we can cure her of her gigantism, which is a challenging task in and of itself. So this is just an example of a reoperation, but it was a particularly satisfying reoperation because we were able to cure this poor girl. But you can see there's a lot of scar tissue and mucosalization. So the key is to do a suprasellar approach. So we opened up a bit more of the tuberculum than they had done before. Here you can see there's some intrathecal fluorescein, so the CSF is green. The optic chiasm is seen at the top. here. So we open up the arachnoid and we're staring right at this suprasellar tumor that the prior surgeon had failed to even expose and didn't remove. And so if you don't do the right opening, it becomes a challenging case because you're working blindly. But if you increase the size of the opening, then it becomes fairly straightforward to see the anatomy you have to see and remove the tumor. There's a little adhesion from the optic chiasm to the tumor, which we're cutting. And then dissect our way around the tumor and remove it and follow the tumor back into the third ventricle to get any residual tumor over there. You can see there's some additional residual tumor attached to the back of the chiasm and the hypothalamus that we had to remove endoscopically, which we do in a careful bimanual fashion, almost like a craniopharyngioma. So postoperatively, she was cured. We, did a nice closure with some with a gasket seal because it was a suprasellar closure. We either use our gasket or we'll use a what's called a button closure, 2 layers. We use either fascia lata or now alloderm, so we avoid making an incision in the thigh, and then try to cover it with a nasal septal flap. We have become more aggressive in the cavernous sinus. This is a reoperation for recurrent tumor in the cavernous sinus. You can see where the tumor has recurred here within the siphon of the cavernous sinus, and we looked at our results. And this is just an example of going after that residual tumor in the cavernous sinus. And you can open up the whole cavernous sinus by removing the bone over the carotid artery. The carotid is intradural, right? So you can just keep taking your exposure laterally. So here the entire cavernous sinus has been exposed laterally. We're using the Doppler because you don't want to open where the carotid is. Often the tumor has pushed the carotid laterally. In this situation, there is some tumor medially and laterally. This was a patient with acromegaly, which is why we went back to get additional tumor. And we widely open up the cavernous sinus, and we'll be working around the carotid. And we have our angled ring curettes. Here it's just a 0-degree scope, and then we take a 45-degree scope and work farther laterally into the cavernous sinus to make sure we get out all the rest of the tumor, heading back to the oculomotor triangle, and then just put a little gel foam in the cavity afterwards. So post-op, you can see that lateral cavernous sinus tumor has been removed. I want to show you this case that we did more recently, a patient who had surgery for Cushing's and was temporarily cured, but then failed. And the tumor had gone right into was sitting in the sella, but it was adjacent to the cavernous sinus. So we decided the tumor had probably invaded through the medial wall of the cavernous sinus. And so here we are dissecting the medial wall of the cavernous sinus off the carotid in order to get that residual tumor out. And we're sharply removing the medial wall of the cavernous sinus. You can see the carotid artery has been totally exposed laterally. And what we found when we got back into the back component of the cavernous sinus was there actually was a little bit of residual tumor. It wasn't just microscopic tumor in the cavernous sinus wall. There was actually some soft tumor within the cavernous sinus itself that we really hadn't appreciated or known, and obviously had invaded through. And only by aggressively removing the medial wall of the cavernous sinus did we find that residual tumor within the cavernous sinus itself. So it's important with these hormone-producing tumors to become a little bit more aggressive than you might otherwise do, unless you can clearly find a pseudocapsule surrounded by normal gland. If the tumor even touches the lateral wall of the cavernous sinus, we will remove that lateral wall. And anecdotally, we think that's increasing our cure rate. You can see there's a little bleeding when you go into the cavernous sinus, but it's easy to control the bleeding with some flow seal or gel foam, and then we go back and make sure we get out all the rest of that tumor. We become very meticulous with that to try to cure this lady all the way back to the clivus and the posterior clinoids that you can see in the back there. We just keep picking away at it to try to make sure we get all of it out sharply and bluntly, even using more scissors to ensure we cut out all of that cavernous sinus wall, and then using more gel foam and flow seal to stop the bleeding. And here we put a little piece of fat, cover it with a nasal septal flap. So what are the cure rates It turns out that in general, if you look at review articles, the cure rates are pretty much 80%, on the range of 80% for everything we do. So this is a meta-analysis that we did many years ago in the first days of endoscopic surgery. It's gotten a little bit better, I'll show you, but the gross total resection rates were 80%. The hormone resolution was about 80%. And even if you look at ACTH, growth hormone, prolactin, it's still about 80%, 85%, maybe 81%, something like that. What correlates with cure rates for functional pituitary adenomas? No suprasellar extension was significant, and no cavernous sinus invasion is very, very important. The rates go down as those things occur. And obviously, the ability to get a gross total resection is important in trying to achieve a cure. Most people have traditionally categorized pituitary tumor size based on their diameter. 3 centimeters, 4 centimeters, greater than 4 is a giant macroadenoma. And we, a couple of years ago, started looking at volume and doing careful volumetrics of our tumors. So there's a graph on the left. You see that we've got the volume of the tumor on this axis, and then we have the maximum diameter of the tumor on this axis. So this is a tumor that's 3 centimeters, less than 3 centimeters is down here, greater than 3 centimeters. This is 4 centimeters, so greater than 4, less than 4. This is based on volume. So these tumors are less than and greater than 10 cubic centimeters. And we have gross total resections or X's, so they're a lot down here in the smaller tumors. Subtotal resection are zeros. And if it invades the cavernous sinus, it's red, right? So the ones that invade the cavernous sinus are more likely to be subtotal resections, so red circles. Anyway, what we found was that the better predictor of whether we were able to remove the whole tumor was not as much the diameter of the tumor, but the volume. And 10 cubic centimeters was a really nice cutoff for gross total resection rates going down. Extent of resection is very high in all these tumors. No matter what, you can get out most of the tumors. So we got out 98% of tumors every time. And a gross total resection, about 75% of the tumors. And then if they had cavernous sinus invasion, it went from 92% to 38% for gross total resection. But 10 cubic centimeters was the biggest predictor of extent of resection. We did another study a little later with a larger group, and this is only looking at giant adenomas. And what were the predictors of extent of resection? Pre-op volume, again, was important. And NOSP grade was important, so cavernous sinus invasion. Growth above the planum, not as much because we could get there. And these were the predictors of extent of resection, excuse me. Predictors of gross total resection, that being extent of resection 100%, the only predictor was really NOSP grade 3 or 4, so lateral cavernous sinus invasion. Was really the main thing that prevents us from getting a gross total resection. And then what were our rates of cavernous sinus removal? That again depended on NOSP grade. So if your NOSP grade is low, your chance of getting out 1 or 2 is high. If your NOSP grade is high, basically NOSP 3 or 4, your chance of gross total resection goes down. And in this early series, it was only about 9%. But the other thing that's important is 6 patients had a preoperative cranial neuropathy, and they all had subjective improvement after surgery. And what I attribute that to is being aggressive, but not too aggressive in the cavernous sinus. So again, all of these patients had tumor in the cavernous sinus that we went after and tried to get out. But if you're not overly aggressive in the lateral cavernous sinus, then your rate of cranial neuropathy is very low. What about pituitary function? If you take out their macroadenoma, how often do you just make them worse? And if they have abnormal pituitary function beforehand, again, this is in a non-hormone producing tumor, does it get better? This was a nice little study I saw that Ed Laws had written. And basically he showed that if you have normal endocrine function beforehand, only about 5% will lose some of your function afterwards. And if you have impaired function, 33% had impaired function preoperatively, only about 7% will recover lost pituitary function. So you basically come out of these operations more or less how you went in. If you have a loss of an axis preoperatively, it turns out that taking out the tumor is not that likely to make that better. There's only about a 7.5% chance that you're going to make a preoperative hypopituitarism actually get better. So it's just something to keep in mind when you're counseling your patients. What about comparisons of endoscopic versus open surgery? We did a meta-analysis early on in the literature, just comparing giant macroadenomas, because we wanted to look only at tumors that were roughly the same size. And if you look at rates of gross total resection for giant macroadenomas and you compare endonasal endoscopic surgery with open transcranial or transsphenoidal microscopic surgery, the rates of gross total resection are much higher when you do an endonasal endoscopic approach. I'm saying much, but it's really about 45% gross total resection rate compared to 30% with a transsphenoidal using a microscope with a sublabial incision. With a craniotomy, it's only about 10% for giant macroadenomas. But this outcome is more dramatic, which is visual outcome. And that's one of the real advantages of the endonasal endoscopic approach, is that we're much better at preserving the optic nerves. Visual outcome is much better when you do an endonasal approach than any of the other approaches for giant pituitary adenomas. And likewise, the complications are lower. CSF leak is actually highest with a craniotomy, believe it or not, compared to an endonasal approach, because we are so good at closing those leaks with fat and flaps and things like that. And the same is true of mortality and hypopituitarism, much greater with other approaches and much lower with endonasal endoscopic. I want to talk a little bit about one of our complications that I hate getting, which is those post-op hematomas. And so we looked at 583 patients undergoing endonasal surgery for pituitary adenomas, and we had an incidence of 1.5% that required a reoperation for sellar hematoma evacuation. And all of them presented with worsening vision. And clot evacuation improved that vision, but the chance that that hematoma would cause a new post-op endocrine dysfunction was very high. So that was the real cost of that hematoma. The vision you can get back if you bring them back to the operating room quickly, but a lot of them lost endocrine function, and that's really upsetting. And so we tried to look at what were some of the risk factors for that. And the main risk factor, as you can imagine, was tumor diameter over 30 millimeters and suprasellar extension. The bigger tumors are the ones that tend to hemorrhage. And if you look only at tumors greater than 3 centimeters, the incidence of a sellar hematoma was about 5%. So it's super important to get really good hemostasis in your larger tumors and to be patient and irrigate for a while before closing to try to avoid that risk. I want to mention briefly 3D endoscopy. We actually were the first people to do 3-dimensional endoscopic pituitary surgery in a small group of patients. And as you can imagine, you know, the surgeries go well. It's about the same. There weren't significant differences in this small group. We have tended to use and move back to the 2D scopes because the resolution is just better. The HD resolution now, the 4K, we now have 4K endoscopes, is better than the resolution on the 3D scopes. And so, you know, if you get used to using a 2D scope, you know, the lack of 3D is not such a big deal. But I do think that eventually when they have HD 3D scopes down the line, the technology is a little better. We'll probably all be using those because it's just more information, you know, and the more information you have, the better your surgery is going to be. We also were one of the first people to combine intraoperative MRI with endoscopy, although we had a very early version of intraoperative MRI, which is this Polestar low Tesla magnet, 0.12 Tesla. And what we found was that, you know, potentially by using the endoscope, we could do a better job than just using the intraoperative MRI. This was sort of our gut instinct. And we have abandoned using the intraoperative MRI for pituitary tumors because my basic feeling and the conclusion is that if you're really good with endoscopy and with angled endoscopes, you don't really need the intraoperative MRI. The intraoperative MRI was helpful in the days when you did it with a microscope, you couldn't really see around corners. And so we did a meta-analysis of the literature and basically said, what is the rate of gross total resection reported in cases where you use an endoscope alone, use a microscope plus intraoperative MRI, or use an endoscope plus intraoperative MRI? And the truth is, it was about the same. So you don't really need the intraoperative MRI if you have the endoscope. And the intraoperative MRI doesn't add that much more if you do an aggressive endoscopic surgery up front. So I still stand by that. So what about long-term recurrence rates? What happens if you get a subtotal resection? Do you irradiate immediately? What's the rate of recurrence? So we looked at that in a group of patients. And this was the literature at the time before we did our study. Recurrence rates for pituitary adenoma of complete resection were reported in the literature to be about 7%, up to 33%. And it depended on the type of adenoma. And if you didn't take out the whole tumor, so there was definitely residual, the recurrence rate was reported to be up to 75%. And about a third of those are symptomatic. So that was the literature before we looked at our data. And I'll show you our data. So we took 190 of our pituitary macroadenomas. These are non-functioning macroadenomas. So we have 190 that have greater than 5 years follow-up, right? So we eliminated ones where we didn't have a lot of follow-up. So everyone has a minimum of 5 years follow-up. And then we followed them for 10 years because we have minimum 5, we followed them up to 10 and said what was the rate of recurrence. So the rate of recurrence was, you can see in these survival bars, if you do a gross total resection, even at 10 years, the rate of recurrence is extremely low. And I'll give you the actual numbers. And if you do a subtotal resection, the rate of recurrence still is pretty low, about 25%. And this rate is about 4 or 5%. The graph on the right is recurrence requiring treatment. So these are all recurrences, but not all recurrences require treatment, right? You can have a recurrence that's a couple millimeters big and you're just going to keep following it. These are recurrences where you actually have to treat the patient. And it shows you also that it's obviously much more likely if you have a subtotal resection, but it's almost zero if you have a gross total resection at 10 years. And even with the subtotal resection, the chance of needing to treat that patient is only about 25%. I'll show you how we got that data. So after gross total resection, probability of recurrence at 5 and 10 years was about 4%. At 5 years it was 4%, 4.7 at 10. But the probability after gross total resection of requiring treatment was around 1%, very low. If we do a subtotal resection, now I tend to follow the patients and not give radiation early. In those patients in whom we gave radiation early, which was 10% of the subtotal resections, they did not progress, but there was 90% of our patients we just observed, which is 57 cases, had a subtotal resection and were just observed. And the chance of them recurring at 5 and 10 years was 20 and 25%. And the chance of them needing treatment was only about 20%. So should everyone with residual get post-op SRS? My answer is no, because only 25% of our patients with residual required treatment and progressed. And so it's reasonable to follow them. This was another paper that I found in the literature talking about the risk of recurrence was low, but if you have residual tumor, but this is short-term recurrence rate. This was out there in the literature. Patients with definite residual visible tumor at 3 months harbor the greatest risk of tumor growth, but regrowth does not occur in all patients, only 6 of 15, 40%. So they also confirmed that not all patients with subtotally resected will recur. Here they said 40%. Our number was 25%. And then we looked at what were the predictors. And you guys mentioned Ki-67, which was important. But NOSP grade was also, if they had a high NOSP grade, they were more likely to recur. If the size of the residual was not really that important. This is for all comers, by the way. Ki-67 greater than 3% was important. The p-value was 0.03. And for revision cases, they had a higher risk of recurrence than upfront cases. So this can help us decide who we should radiate. So this is also looking at those, this is now just subtotally resected tumors. The prior one was all tumors. What were the predictors of regrowth in subtotally resected tumors? Well, cavernous sinus residual, size greater than 1 cubic centimeter for subtotally resected tumors was important, and revision cases. So if you put it all together, the ones that I think need upfront SRS are if you have a subtotally resected tumor, the residuals in the cavernous sinus, it's greater than a centimeter, and your Ki-67 is greater than 3%. These are all factors that are going to lead you to potentially say, let's radiate up front. Let's not just follow this tumor. But if you have a smaller tumor, lower Ki-67, residual not in the cavernous sinus, you probably can just follow that tumor and not need to do radiation. So there may be an indication to radiate up front based on markers of high risk of recurrence. What are the results of reoperation? How often do we go back and do a reoperation 5 and 10 years later? And how do we do? What are our results? Well, first we did a review of the literature on that subject of reoperation for pituitary adenomas. We compared endoscopic to microscopic. This is the number of cases. The gross total resection rates were slightly higher for the endoscopic cases than the microscopic cases. Endocrine remission slightly higher, but not that dramatically different. Visual improvement, however, was more significantly different and better in the endoscopic than the microscopic cases. We looked at our own series of reoperations, and we had done, we achieved a gross total resection in 58% of cases, so it was pretty good. And we got a gross total or near total resection in 92%. So extent of resection is very high. So if you go back and operate endoscopically, you know what you're doing, you can get out most of the tumor most of the time. The average extent of resection was 94%. Rate of gross total resection, obviously lower in NOSP grade 3 and 4. Post-op CSF leak was not that high. It was only one case, 2.4%, which we were able to stop with a lumbar drain. It didn't need a reoperation, probably because we had a nasosubtle flap. Visual improvement, visual field improvement, we found in 53%, endocrine remission in 78%, and new DI in 5%, and new anterior pituitary deficiency in 10%. So the results of reoperation are actually quite good. And I generally prefer reoperation over radiation for recurrent tumor if I feel like I can get out most of the tumor. Obviously, if the recurrence occurs mostly in the cavernous sinus, I'm going to favor radiation over surgery. But if the recurrence is in the sella, in the clivus, in the suprasellar cistern, I think that reoperation makes a lot of sense. What about our learning curve? So after we had done 1,200 cases, I basically eliminated the first 200 cases and looked at my learning curve over the next 1,000 skull-based cases. So this is all endoscopic cases, not just pituitary tumors, but it applies to pituitaries as well. Obviously, there's a steep initial learning curve, and most of the data on the learning curve is about the initial slope of the learning curve, not about the tail end of the learning curve. So the question is, what happens after you've done 700 cases? Are you still getting better? There's little literature on that. And there's some different theories on it. So some would say that after you acquire your skill, phase 1 and phase 2, you get through the steep end of the learning curve, either you take on harder and harder cases, right? So you get a little bit worse, your results are a little worse, or you plateau because you master it, or you actually get better because even after 700, 800 cases, it's possible you're still becoming a better and better surgeon. So our question was, which of these are we going to find? Are we going to find that the more we do it, the worse our results because we're taking on harder cases? Do we just plateau because we've mastered the technique, or do we keep getting better over time? I should take a poll right now and ask you what you think is going to happen, but I'll show you what happened. And the answer is we keep getting better. So for pituitary adenomas, which is the graph on the left, our rate of gross total resection for all comers was 71%. But if you look at the first 500 cases and compare it to the next 500 cases, it actually went from 67 to 75%. And remember, we eliminated the first 200 cases. So this is even after doing 700 endoscopic cases, we're still getting better with the next 500. And we found that with every pathology. Meningiomas went from 55 to 70%. We didn't have enough numbers for statistical significance. Craniopharyngiomas gross total resection went from about 50% to 70%, and chordoma 56 to 100%. So persistent improvement even after 700 cases, the tail end of the learning curve is not flat. We also, if you just look at pituitary tumors and you look at our rate of, the first one was the rate in non-functioning tumors of a normal hormone function afterwards. That stayed about the same. But if you look at the rate of hormonal cure, for all functioning adenomas, it went from 83% to 89%. So we got up to about 90% hormone cure in that tail end of our learning curve. And that was true for prolactinomas, growth hormone producing tumors, and ACTH producing tumors, which is here. So for prolactinomas, we went from 77 to 88%. For growth hormone, 71 to 92. For ACTH, 79 to 86. Now, we didn't have the numbers for this to be significant, but when you combine them all together and you look at all functioning tumors, it is statistically significant. So this just means you need more numbers, but the trends are there for all subtypes of tumor and obviously significant for all. So this is another advertisement for using a skilled surgeon, because even the surgeon who's done 700 cases is not as skilled as the surgeon who's done over 1,000 cases. So you just, in my opinion, just keep getting better and better over time. I'm sure at some point that will fade, but I hope to keep getting better and better. One of the other things we found was that our rate of use of lumbar drains went down as we gained more confidence, and our use of the incidence of intraoperative cerebrospinal fluid leak went down as well. So that was good. The procedure length actually went up in some cases or stayed the same. We didn't necessarily get faster, and I think that's because we're taking on harder and harder cases. So it just took longer to get the harder cases done over time. Sometimes it didn't change that much, but there really was definitely not a decrease in procedure length. If anything, there was an increase for metastases, an increase for chordomas that was significant, but they all went up a bit as well. Rate of post-op CSF leak is very low. So for pituitary adenomas, it's 0.8%. And in general, there was no significance in the change of CSF, post-op CSF leak. For meningoencephalocele, it did go down. For meningiomas, it went up a little bit, but it really, and you can see that the rate of post-op CSF leak is different, right? For a pituitary tumor, it's about 1% or less. For meningioma, it's about 7%. For craniopharyngiomas, it's about 3%. For chordoma, it's about 4%. But I started to wonder, why is it that my rate of CSF leak after doing all those cases didn't change? And the answer is that we had a pretty good algorithm for CSF leak repair. And that's very algorithmic. So once you know how to use a gasket and a nasal septal flap or a button in a nasal septal flap, it works well. And you use it in all the patients, they tend to do pretty well. So our CSF leak rates didn't really change. Whereas doing a gross total resection of a complicated tumor takes 1,000 different maneuvers, and every case is different. And there's where the learning curve really comes into play, because it's it's a much more complicated procedure than just doing the closure. I want to say a word or two about COVID. We had very, very high rates in March and April. And it was a very scary time, and they shut down our elective cases March, April, May. Really, for 3 months, we could do no elective cases. And at one point, we had 2,000 COVID patients at New York Presbyterian Hospital. But the really scary part was that we had 760 patients in the ICU in April. So it wasn't just all our ICUs were filled, our ORs were turned into ICUs. And they were all on a ventilator, right? 750 of those patients were on a ventilator at New York Presbyterian Hospital. Now, right now, we actually have about 900 COVID patients in the hospital, but only about 100 are in the ICU. So our rate of ICU use and on a ventilator is like 50. It's much lower. So that's why things are much better now, even though we're having another peak. We know how to manage it much better, and so they're not as sick. So we all saw this report out of Wuhan of a patient who had an endonasal surgery, and the initial report was that everyone in the OR got very, very sick. But then they made another report saying that that people in the OR were not sick, and so it was a very ambiguous message that was sent. The first words were that people were getting sick from these transsphenoidal surgeries without protection. And then there was a case report saying that they were not sick, and it wasn't clear what to believe. But when we had to do a transsphenoidal, we developed this mask, this facial mask. We're actually decided to patent it, and we're going to try to build it and market it. And we've changed the design quite a bit. This was an early design, but we would do the surgery. We basically put a suction here and just suck all the particles out while we did the surgery. And it's something to think about, you know, in other countries where there may still be some patients who don't get tested. We test all our patients now before surgery, and they're negative, so we know that they don't have COVID. But if you don't have that ability, you may want to use some sort of a facial suction or antechamber to suck the viral particles out. And we're going to try to mass produce that for commercial use. So that's the last thing I want to talk about. In conclusion, surgery for pituitary adenomas requires special expertise. Experience ideally should be done concentrated in the hands of centers of excellence. The key is to find the pseudocapsule, remove the tumor en bloc. Extended approaches increase your extent of resection, but need to be performed with experienced surgeons or complications will ensue. Endoscopy increases rate of gross total resection in larger tumors, particularly suprasellar cavernous sinus. And cavernous sinus exploration makes sense for soft, easily removable tumors to avoid cranial neuropathy. But SRS is effective. There's no reason to go into the lateral cavernous sinus in a non-hormone producing tumor. Volume greater than 10 cubic centimeters, lateral cavernous sinus invasion do predict decreased extent of resection. Intraoperative MRI I find less useful if you're skilled with endoscopy. If your pituitary function is normal, 5% will deteriorate. If abnormal, about 8% will improve. Long-term recurrence rate is very low if you get a gross total resection. Can monitor patients with subtotal resection, withhold SRS unless there's interval growth or there's residual that's greater than 1 cubic centimeter and a Ki67 greater than 3%. Reoperation works very well, particularly good in young patients. And the tail end of the learning curve for complex neurosurgical procedures is very long, and expertise is a constantly moving target. Thank you very much.
We could have one or two questions if that's okay with you.
Yeah,
I wanted to ask you something. If you have 10 minutes, I had a very brief talk, and I think that talk would be very interesting from your point of view as well, because it's a very small talk on craniopharyngiomas, 10-minute talk, and there is a reason I'll mention it in a second. But first of all, I had a question. I think you've been very clear about endoscopic pituitary surgery for functioning and non-functioning adenomas, about the experience, about the number of cases. Do you think in this day and age, people should start doing pituitary surgery with no exposure or training in pituitary surgery and try and learn the technique themselves? Do you think this is something?
No, I think that, most training programs are doing endoscopy. So during your residency, most residents should get exposed to endoscopic surgery. If you've never been exposed to it, there are courses you can take. If you really want to train yourself, it's not like nobody can learn it, I think, but you have to take some courses and you have to work in a cadaver, and then you have to find an ENT surgeon you can work with who will help you do the approaches. If the ENT surgeon can do the approach well, then the surgery itself technically is not that much different than doing it with a microscope if you have the right instruments, but you have to just take your time and make sure you have the right training beforehand. So I wouldn't just give it a go if that's what you're asking, if you've never done it before. I personally took a course before I did my first case. I flew to Italy and did a course there and watched their surgeons operate and worked in a cadaver myself, and then worked with an ENT surgeon before I did my first operation. So it's possible to train yourself, but it does take time.
Well, just a brief thing I'll mention that I've been doing it for the past 8 years, and I was trained at Queen's Square National Hospital for Neurology and Neurosurgery before setting up a whole center back in the United Kingdom, and then coming back to England. Coming back to Islamabad, Pakistan, and I've managed to establish to a certain degree minimally invasive pituitary service at Shifa International. But there are two of us, one of them is also a very senior surgeon, and he's also doing them, and I'm doing them as well. But we are managing to start a big center here. And you were quite clear about it. The more you do, the more your expertise, so the more concentrated a surgeon is doing pituitary surgery endoscopically, the results are going to get better and better.
Yeah.
There is one more thing. Can you add to that, Ted?
You mean to the improvement over time? Is that what you're?
Yeah, I think you were quite clear about that.
Yeah, I mean, I was surprised to see that my results were getting better even after that many cases, but they do. You know, what can I say? You just the more you do it, the better you get. I think until your hands start shaking and you start to lose your vision, experience and knowledge become more important. And so, luckily, I'm not on that tail end of the learning curve that eventually we all get to. But I think you do see this slow improvement over time that just keeps going. And I hope to continue improving, but I think it also is important to listen to what other surgeons are doing. I've changed what I do based on lectures that I've gone to and watching other surgeons do things. And I thought, wow, I never thought of that trick or that technique. What a great idea. I'm gonna start doing that. And I think we need to each help each other get better, you know, and I don't want you repeating the mistakes that I made. And the same is true of me repeating mistakes that other centers made. It's just not fair to our patients.
Okay. So Ted, I had a small talk about craniopharyngiomas, because currently the status quo is that in Pakistan there are very few or very few, even though I tried to find who is doing endoscopic craniopharyngiomas at present, and I was struggling to do that, but I'm sure there are some which I missed. I had a very small talk about convincing endocrinologists and all the listeners at present regarding offering surgery for craniopharyngiomas, endoscopic. It's a small 10-minute talk, and I was hopeful if you could back me up on that, considering you're the leading endoscopic surgeon. Would that be okay, just a 10-minute talk?
Sure.
Okay. So I think I've already introduced myself, and I wanted to talk about craniopharyngiomas, and the reason for inviting Ted was that, considering his expertise in this, are certainly more than me. I've been doing them for 8 years only. This is my theater setup. I think Ted showed his as well. This is my theater setup. We use Stealth 8. We've got endoscopes. We've got, and as I said, I keep the things slightly minimal in terms of that. I've got, like, I tend to get, sometimes I use a holding arm, or sometimes I ask the residents so that they can get their hand-eye coordination in terms of when I'm doing the surgery. So in this surgery, I've got my resident helping me out. Just one case, I've just put it as an example. So Ted, you can cut me or comment on it anytime you want during the presentation. So this is a case that was referred to me from the periphery. Actually, this patient presented with visual loss, and I've got the CT on the left side and the MR post-operative on the right side. This patient, you can see quite clearly the sella had not expanded. There was a differential ongoing between craniopharyngioma and adenoma. And I think finally the surgeon decided that the patient needs to be referred to a person who could do both, either a cranio or a adenoma. So this patient got referred to me, and I did this. I mean, you can see that it had a very small window, and took that out through the nose. This was actually turned out to be a adenoma, which was quite clear on the MRI scan preoperatively, which I do not have available. But this patient traditionally, I mean, would have gone for a craniotomy around here if it would have stuck in the periphery and wasn't referred to Shifa International. Just a little bit about me. I mean, of course, craniopharyngioma surgery was initially started by Victor Horsley, the department that I was trained in. And one of my major trainees, who initially back in the day trained me in microscopic pituitary surgery, was Michael Powell. And then gradually he pushed me towards learning endoscopic surgery. And then I moved into endoscopic surgery. And since then I've been doing endoscopic surgery. Michael Powell is now retired, but we are still in touch. I'm going to skip that bit. I'm just going to talk about craniopharyngiomas now. I think I have been listening to Ted's talk as well, which was on craniopharyngiomas from above or below. And I think I took some points from that. And whenever you're doing a craniotomy for a craniopharyngioma, I think most of the anatomy that you come across, I tend to do craniotomy as well in certain cases. And that is, you come across the normal anatomy. So you're looking at the optic nerves, the carotid, the third nerve is just in the corner as well. and there's a lot of retraction on the brain. And I want you to talk about the pros and cons of surgery for craniopharyngiomas. Some of them I took from Ted's previous talk as well. The pros of doing a craniotomy is that you tend to be operating, you could operate easily on large tumors which are involving middle fossa, because with endoscope, you tend to be mainly in the midline. And in Pakistan, I mean, the craniopharyngiomas that I've seen have been fairly large, and there has been they tend to present quite late. And you can't do an endoscopic approach if they don't have any sphenoid sinus. On top of that, I've seen like people who are doing craniopharyngiomas in Pakistan, they've got experience of 30 plus years of doing craniotomies, and they tend to be quite good at it, at craniotomies, and are doing surgery for that. And it's actually quite common if you are doing vascular surgery, craniopharyngiomas surgery, and craniotomies. People tend to just go straight towards craniotomy. As you mentioned, I mean, it's quite clear whenever we are doing endoscopic surgery, there tends to be CSF leak, and there are different ways of repairing it. Probably I'm different to Ted Schwartz, but he's got more experience. And if you're doing craniotomies regularly, I think your operative time is quite less. The cause of craniotomy, from my point of view, I mean, there are always, if you're doing a craniotomy, it tends to be a larger incision, the recovery is slightly prolonged. Of course, if you're going through the normal anatomy, or you're moving the normal anatomy around, getting to the tumor from different angles, there could be nerve injuries and perforator injuries, and of course, retraction injuries. Revision surgery could be more challenging if you're doing it. And hypothalamic complications can be both with endoscopic or with the craniotomy. And even though the craniopharyngiomas, some of them I've come across here, I mean, gross total resection may still not be possible, even if I'm doing a craniotomy or any senior surgeon doing a craniotomy for that. Endoscopic, I'm not going to go into the extended endoscopic approach. I think I just wanted to briefly go into the anatomy, that when we are doing endoscopic surgery, which Ted has mentioned quite clearly, you tend to approach it from below. And all the important structures are lying superiorly. So when you're coming from below and you're looking at the craniopharyngioma or pituitary adenoma, you're actually away from all the important structures, and you're going into the tumor and trying to excise that. And of course, you need to know the anatomy. There are the portal system, and there are hypophyseal branches. Sometimes you have to sacrifice them. Sometimes you even have to sacrifice the stalk in certain patients to achieve gross total resection. But there's a long debate about children and adults and how to do that. A brief anatomy of the view that the way I do, for example, approach adenomas and craniopharyngiomas, the window is slightly different for adenomas because you tend to be going for adenomas around here, while if you're going for craniopharyngiomas, you need to go above the pituitary gland and below the chiasm. And I think the pros from my point of view, and I think, as I said, I've taken some points from Ted's previous talk as well, is reduced manipulation of normal structures. Visual outcomes tends to be better. I mean, I have been doing them before, but I cannot show the videos of those craniopharyngiomas because they were done in a different country. Avoidance of craniotomy, the mortality rates tend to be low. Of course, we are doing them minimally invasively. We are going through the nose. Higher patient satisfaction. This is what I've seen in all endoscopic surgery over the last 8 years that I've been doing, which is much less than any other surgeon or Ted Schwartz. Patients tend to be much more satisfied if you tend to offer them endoscopic surgery. Now, this is something I think, in which Ted mentioned quite clearly. I mean, and it's very important for like whether you can compare endoscopic resection to craniotomy for a similar sized tumors. I mean, I didn't want to go into numbers, crunch numbers here, but I just wanted to say that if you've got a smaller enough tumor lying in the midline, the chance of you removing through the nose is the same if you go for a craniotomy, because I think you're approaching the tumor directly, and you tend to be very away from the other important structures, you are approaching them from below. The cons, I wanted to mention the cons of endoscopic surgery as well, because you can only access smaller tumors. I mean, it's very variable. I mean, of course, Ted has got much more experience, so he seems to be going for larger tumors as he's progressing. I think my numbers are less than him. I tend to go for like maybe around 3 centimeter at max in my experience. CSF leak tends to be high, but it depends on the closure. I mean, I tend to use nasoseptal flap, which everybody is using. But I think Ted has got a very good paper on different types of seals that he uses. I tend to use also Vomer as well, and also Dura seal on top of that. Nasal symptoms, sinusitis, I put that there, but I have not come across any significant symptoms from even in pituitary surgery or in craniopharyngioma surgery, whether the patient get any symptoms from sinusitis or not. But the patient satisfaction overall has been okay, but I've put that there. Of course, it needs higher training and experience. I mean, I've spent the last 20 years learning and trying to go for the surgical excellence and learning from people, different people that I've mentioned, and maybe distant learning from Ted Schwartz as well, who's listening at present, hopefully. It has a longer learning curve. I mean, as I said, Ted mentioned himself that he's learning and getting better now after close to 20 years, and I'm sure I'm doing the same as well. You do need specific instruments. You can't just start this surgery without specific instruments. I mean, I don't know what instruments Ted uses, but I mean, I tend to go for the Capablanca set. Of course, the working corridor is pretty much small. You're working between the two carotids. And it can take longer. It does take longer than a craniotomy. And I mean, Ted is a proper, Ted can explain much more clearly. I mean, how many I've approached all these 4 pathologies through the nose and tend to do them. And my message was this, from my point of view, for our neurosurgical community and endocrinology community, is that minimally invasive surgery is here to stay. Of course, higher training or experience is compulsory. Patient selection is the key. You can't just suddenly start on big tumors and offer them surgery for, endonasally. And if you're not sure around the country, especially in the periphery in Pakistan, like what to do with the patient, it would be better to send it to major hospitals and surgeons who tend to be, who are doing them regularly or on regular basis. Ted, you want to add anything to that? It was a very brief talk. I just wanted to go through and try and make sure that we could establish a craniopharyngioma service as well as a pituitary service as well.
I mean, that's craniopharyngiomas are a whole other topic. I agree that I do tend to do the majority of them endonasally, and I find that the outcomes are better, not only in my hands, but if you carefully look at the literature, the biggest difference is really visual outcome, that the visual outcome tends to be better if you come in from below, because if you come in from above, you really have to manipulate the optic nerves. But that's assuming that you're skilled enough to get a good closure and your CSF leak rates are low, which if you know what you're doing, they should be.
So Ted, I had these images for you that I kept for you. I mean, this is a tumor craniopharyngioma. I mean, would you go for endonasally, or would you go, I mean, of course, I mean, what do you think? This is something feasible via endoscopic approach?
Yeah, as I mentioned before, I do almost all of my craniopharyngiomas endonasally, unless they're in the middle fossa. That's really the only reason I would potentially not do it. It's very hard to get lateral to the carotid artery and lateral to the carotid bifurcation. Sometimes the cysts can go that far lateral, in which case I may not do an endonasal approach. Mm-hmm. That's a rare case that I see.
Okay. Well, Ted, you've been very kind. I think we've learned a lot from you, and I managed to slip a message through as well in your presence regarding craniopharyngiomas. And hopefully we will be inviting you in due course as well to Islamabad, Pakistan, post-COVID area. And I think we've all learned a lot from you. I think we're going to end the session on this by saying that I think welcoming Ted Schwartz and giving us the great lecture and talk and sharing his experience with us, and also our endocrinologist sharing the experience and around endocrinology and patients, pituitary patients that we tend to deal together. And we've got a second session planned as well for the audience. I think Hu Defoe is coming and talking about awake glioma surgery, awake surgery for low-grade gliomas, which is another thing. I think Ted also does oncology and epilepsy surgery and minimally invasive surgery. And I think we tend to share that. So we'll be welcoming Hu Defoe next time. And Ted, you're more than welcome to join next time as well.
Thank you. Thank you so much.
Thanks a lot.
Pleasure
Take care.
To be invited to hear what you had to say. Take care. Bye-bye.
Thank you. Bye-bye.